Hello, everybody, and welcome. Today's speaker is Dr. Sheromna Sewpersad. She is a chemical pathologist with an MBChB and MMed in pathology from the University of Pretoria, with an FC pathology from CMSI in chemical pathology. She joined Pathcare in 2024 and has experience in clinical biochemistry, laboratory medicine, and interests in point of care testing, as well as endocrinology. Thank you so much for coming to present to us.
Thank you very much for the introduction. And thanks everyone for joining this learning session. Everybody and me can learn. So I'll be going through celiac disease. So the presentation is just titled From Clinical Suspicion to Lab Diagnosis. So I'll just go quickly through a definition of celiac disease, then wheat plays an important part in understanding pathophysiology. So wheat and gluten-related disorders, just touching on those. And then the pathophysiology, the clinical presentation, one type of classification of celiac disease, then the diagnostic algorithms that we can use, the laboratory tests that are offered, and then just a slide on the treatment of celiac disease. So what is celiac disease? It's defined as a systemic autoimmune disorder induced by cereal prolamins, and the most well-known of those being gluten, in genetically predisposed individual, and they experience a variety of gluten-dependent symptoms, specific antibodies, and they generally have the presence of HLA-DQ2 and or DQ8 histocompatibility antigens, and these patients also experience enteropathy. Just a little bit of the history of grains. Long ago, man was a simple hunter-gatherer. His diet consisted of fruits, nuts, and the occasional feast of meat. But eventually, he learned to cultivate plants, and the agricultural revolution began. And soon, the hunter-gatherer way of life was replaced by the domestication of crops and animals. So the most common of that, or domestication of crops, was that we grow wheat. So in order to understand the pathogenesis and the actual component which causes the disease process to start, it's important to understand the anatomy of the wheat grain. So the wheat grain contains the hull, which is the outer layer of the whole grain, and that protects the kernel from fungus and pests. Then just inside is the bran. That's the outer skin of the grain, and that contains fiber, antioxidants, B vitamins, and trace minerals. And then what consists of the main part of the grain is the endosperm, and that is the energy supply to the germinating part of the seed. As much as 85% of the grain's protein comes from this endosperm area. And then the germ is the embryo of the seed. It forms a sprout if pollinated, and it contains B vitamins and phytonutrients. So the four main plant proteins are albumin, globulin, prolamin, and gluten. So albumin and globulin are generally put together, and they make up 15 to 20% of the total protein content of the endosperm. But the important ones for us to note is the prolamin and lutein protein fractions, because these are the pathogenesis-related proteins. They contain lots of glutamic acid and proline, and they are the storage or defense proteins, and they make up 80 to 85% of the total protein content of the endosperm. So looking at the different grains, they have different prolamins and glutenins. So wheat, barley, and rye are the grains which are normally associated with causing symptoms in patients with celiac disease. So their prolamin and gluten are specifically those mentioned in the table. So for wheat, it's gliadin and glutenin. For barley, it's hordein and hordenin. For rye, seculin and seculin. And then oats is a bit of a contentious one, because in most areas, they say that oats are not they don't contain the pathogenic amino acid sequences that do cause the symptoms. But yeah, sometimes they find it does and sometimes they don't, but it is in general not supposed to cause disease. So technically, what is gluten? It is a specific prolamin and glutenin called gliadin and glutenin, which when mixed with water form this mesh-like structure. Technically, that's the only thing that is gluten. But when it comes to the standpoint of celiac disease, the term gluten is used to describe certain sequences of amino acids found in the gluten and prolammin protein fractions of all of wheat, barley, and rye. So some of the gluten-related disorders, the most common being celiac disease. You also get dermatitis or fattiformis, a gluten-related neurological manifestations, non-celiac wheat sensitivity, also known as gluten sensitivity, and then a typical wheat allergy. So just touching on gluten sensitivity, consuming wheat in these patients trigger intestinal and or extraintestinal symptoms of bloating, abdominal pain, fatigue, brain fog. But this is without the autoimmune damage of celiac disease or the allergic reaction of a wheat allergy specifically. It's suspected that other components in wheat may trigger the symptoms, and those components may be fructans or amylase trypsin inhibitors, for example. Then in terms of your wheat allergy, it's a classic food allergy mediated by IgE antibodies. So those are the typical allergy symptoms, hives, itching, nasal congestion, wheezing, could also cause digestive distress, or even in very severe cases, anaphylaxis. And that's a typical allergy diagnosis, so wheat-specific IgE, or you could do a skin prick test. So going back to celiac disease, there's just a video that I'd like to play from Osmosis, which describes the pathophysiology.
So, if somebody with celiac disease eats a wheat-based pizza, it's broken down in the stomach into gliadin and a whole lot of other stuff. Gliadin's a tough little bugger, though, and resists being broken down by all sorts of enzymes. When gliadin gets to the small intestine, it's bound to secretory IgA in the mucosal membrane, which is an antibody that helps protect gut epithelial cells called enterocytes from toxins and pathogens. Usually, things bound to secretory IgA are marked for immune cell destruction. But in celiac disease, this gliadin IgA complex, for some reason, binds to a transferrin receptor, TFR, which is usually used to help absorb iron and seems to be overexpressed in patients with celiac disease. Once bound to this receptor, it's transcytosed across the cell from the apical to the basolateral membrane, or across the enterocyte and into the lamina propria, which is the thin layer that lines the gut wall. Once there, an enzyme called tissue transglutaminase, or TTG, cuts off an amide group from the protein. Deamidated gliadin's then eaten up by macrophages and served up on its MHC class II molecules. Remember, macrophages are in the gut and are always doing a bit of gut sampling, where they grab proteins, which a lot of times are from the food we've eaten, and show them to the immune cells. MHC stands for Major Histocompatibility Complex, and is the name of the serving platter for the stuff that's served up. And this is a normal way to make sure that there are no pathogenic bacteria lurking in the gut. Now, there are a ton of different types of MHC class II serving platters, and these serving platters are encoded by genes called human leukocyte antigen genes, or HLA genes. These genes determine what things the MHC class II molecules serve up. So, for example, HLA-DR encodes for an MHC that serves up something different than the one HLA-DQ encodes for. Researchers have noticed that patients with celiac disease typically have specific deamidated gliadin serving platters, such as one called HLA-DQ2 or HLA-DQ8, which is an interesting clue that kind of helps us better understand celiac disease. It's at this point, when the HLA protein serves up gliadin, that the immune system kicks in. The macrophage throws it up top and is like, hey, guys, what do you think about this molecule? And the T helper cells, also known as CD4 plus T cells, from the immune system that recognize the gliadin, zoom over and are like, yep, I'll take it from here. And they release inflammatory cytokines, which are molecules that initiate inflammation, like interferon gamma and tumor necrosis factor, which can directly damage and destroy epithelial cells in the villi of the small intestine. Not only that, though, the helper T cell stimulates B cells to start pumping out IgA antibodies against the gliadin, the transglutaminase enzyme, and endomysial antibodies, or EMAs, which are actually another type of antibody for transglutaminase, but for transglutaminase found in the endomysium, which is this layer of connective tissue around muscle fibers. It's not totally understood why these are produced, since they don't seem to cause any muscle-related damage or symptoms. It's possible they're produced just because of their structural similarity to the transglutaminase in the lamina propria. One thing they are helpful for, though, are making a diagnosis. Finally, the helper T cells also recruit killer CD8 plus T cells, which is when things start to get nasty. Killer T cells are drawn to and destroy cells undergoing inflammation. So, in short, as patients eat gluten, the immune system is stimulated and epithelial cells are destroyed. It's also possible that the destruction of these cells lets more gliadin across the epithelium, since they're not bunched together as tightly as they were before. Tests for antibodies in the blood are used clinically to screen for celiac disease. IgA blood tests for both TTG and endomysial TTG are more than 98% sensitive and specific, and are a super effective screening test. Tests for IgA or even IgG antibodies against gliadin are less sensitive and specific, but are still pretty effective tests to screen for the disease. For reasons that aren't super well understood, a small amount of patients are IgA deficient, meaning they aren't able to produce any IgA antibodies in general. So in this case, they didn't have an IgG screening test done. Now, so if some
pathogenic mechanism, so you basically have the resistance to digestion of your gliadin, then your deamidation by your tissue transglutaminase, and then your immune activation, which leads to the whole sequelae of the damage to the small intestine. So what is a clinical presentation of celiac disease? It's a lot of things. The most common or typical symptoms are your intestinal presentation. So the patients can present with chronic diarrhea, steatorrhea, abdominal bloating, nutritional deficiencies, and weight loss or failure to thrive. Also, constipation is noted in some patients. Then for skin, you get your edemas, the TPA, the hepatiform dermatitis, some stomatitis. Endocrine-wise, your infertility, impotence, amenorrhea, hypercortisolemia, all because of your immune system being activated and your nutritional deficiencies, which lead to these conditions also. And then hematological, most commonly being your iron deficiency anemia. And you can also get hemorrhage from your damage to your intestinal mucosa, dermocytosis. Hepatic-wise, hepatic steatosis, autoimmune hepatitis, and neurological and psychiatric. It's actually quite interesting. There has been a link between mood disorders and psychosis and celiac disease of such patients. Also, you can have actual organic disease, like peripheral neuropathies, demyelinating lesions of the central nervous system, and this. So it's not super specific. Basically, your patients can present with anything, but in general, it's mostly the intestinal symptoms. But also the nutritional, your iron deficiency anemia is most common, but you can also magnesium, folate, B complex, and vitamin D and K deficiencies. On your immune side, your patients can just present with allergies, an immunodeficiency, and just in general immune vulnerability. And on skeletal side, because of your deficiencies, you can have rickets in your kidneys, and then your adults osteopenia, osteoporosis, and pathological fractures. It's not super specific, but basically they can present with a whole range of symptoms. Classification of celiac disease, there have been a few proposed over the years. The one that I'm going to describe is that of typical and atypical. So under your typical, you have responding, resistant, and refractory. And under your atypical, you can have silent, latent, and potential. So your typical celiac disease have the gluten-dependent symptoms. They have positivity for one or all of the specific antibodies. So that's your tissue transglutaminase, anti-endomysium, and anti-gliadin. And then they generally are positive for your HLA-DQ2 or 8. And that they have histopathological changes on your duodenal biopsy, according to the MARS classification, which I'll describe later. Sorry. So the types under your typical presentation, as mentioned before, is your responding, resistant, and refractory. So your responding celiac disease patients, if they are on a gluten-free diet, there is improvement of your symptoms within 6 months. And also histologically, if biopsies are done, there is resolution of the changes that are found. Then in terms of your resistance, typical presentation patients, if your symptoms tend to recur within 6 to 12 months, despite the adherence to strictly gluten-free diets, it's likely that the patient has comorbidities with something like eosinophilic enteritis, food intolerances, ulcers, diverticulitis, or Crohn's. So it's important to just look for other comorbidities. And then in patients labeled as refractory, if the patient does not respond to the gluten-free diets even after 1 year, and it's likely due to a clonal increase or the presence of aberrant T lymphocytes. And refractory celiac disease is also further split into type 1 and type 2, and that depends on the histopathological examination of your duodenal biopsy, the percentage of activated T cells that are found. In your atypical presentation, they're silent, latent, and potential, so they can include both the intestinal and extraintestinal symptoms. For your silent patients, the histological manifestations are less marked than that of the overt disease or found in like Marsh classification 2 and above. So the histological damage is not specifically clearly attributable to celiac disease. These patients might not have the immune markers, so serological markers that are picked up in the blood. They might be inactive, but they do have HLA, generally HLA-DQ2 or 8 positivity, and often they have increased total IgE values. Then in your latent patients, they also have symptoms that can be typical or atypical. Here you have positive serological markers. You also have the HLA-DQ2 and 8 positive. At the time of examination or discussion, the patient does not have histological damage that was present. And that's what basically differentiates it between the potential and latent, because the potential, there was no evidence of histological damage ever. But in your latent, it's the patient might have had histological damage to the intestinal mucosa, but it's improved. So this is the histopathological classification on your duodenal biopsies. It's the Marsh classification. It basically has to do with your intraepithelial lymphocytes, the intestinal crypt hyperplasia, and villus atrophy. So I'm not going to go too much into it because I'm not a histopath, but it's important to know that the Marsh classification from type 2 is very suggestive of your celiac disease. So how can we work towards a diagnosis? So I want to start with the pediatrics. The European Society of Pediatric Gastroenterology, Hepatology, and Nutrition, they have a very nice algorithm. So basically, for initial testing, they recommend the combination of total IgA and tissue transglutaminase IgA. And they say that that test combination is more accurate and it's the best for the initial screening for patients with suspected celiac disease. And then the updated guidelines speak of this no biopsy approach. So if the patient has a tissue transglutaminase IgA value of more than 10 times the upper limit of normal, they recommend that you test for endomysial antibodies. And if that is positive, then on a second sample, then with discussion with the parents and patient, it's possible that the diagnosis of celiac disease can be made without a biopsy. However, if your tissue transglutaminase IgA is less than 10 times the upper limit of normal, it is recommended that biopsies be done to decrease the risk of a false positive diagnosis. And in kiddies, the HLA-DQ2 and 8 testing and the presence of symptoms are not obligatory criteria for the serology-based diagnosis without biopsies. So this is the algorithm by the SP-GAN. So the light blue, the top section is for the initial stages of testing, so mostly your GPs, and then the dark blue sections is for your specialist care. So if a patient presents with a clinical suspicion of celiac disease, or if they're in a high risk group, so if they have family history of patients being positive for celiac disease, it's recommended that you measure the serum tissue transglutaminase, IgA, and total IgA. So if that is negative, then we look at the next section. But if it is positive, at your base primary care level, then they recommend referral to a specialist. So if you are the specialist, so you review the results of the initial tissue transglutaminase IgA antibodies. If they are positive and they are greater than 10 times upper limit of normal, as mentioned before, test for EMA. And if that's positive, then the celiac disease diagnosis is confirmed. But if your tissue transglutaminase results are intermediate or discrepant, then we see the next section, so section B. And if your tissue transglutaminase IgA concentration is less than 10 times the upper limit of normal, or your tissue transglutaminase IgA is greater than 10 times the upper limit of normal, but on your confirmatory EMA testing, that's negative, then a biopsy is recommended. If your tissue transglutaminase IgA, so your initial testing was negative, it's important to review the initial total IgA. So if your total IgA is normal, you need to consider the risk of false negative serology. So that can be caused by a low or short duration of gluten intake, your immunosuppressive medication, or extraintestinal manifestations. If there was no risk for false seronegativity, then your patient likely does not have celiac disease. However, if your total IgA is low, or there is a risk for false seronegativity, then you move on to the next table that's below. So if there's a risk for false seronegativity, you can consider HLA determination. If your HLA DQ2 or 8 is negative, so neither of them are positive, then celiac disease is unlikely. You should consider other diagnosis. But if they're positive, then you can follow and retest on a normal gluten intake and consider biopsy if you have a high index of suspicion. If your total IgA is low, you do the IgG test. So that will be your tissue transglutaminase, EMA, and deamdatogliadin protein. So if your IgG tests are positive, then you should refer your patient for a biopsy. But if your IgG tests are negative, also then go through considering the risk of a false seronegativity. If there is no risk, then it's unlikely that your patient has celiac disease. But if there is a risk of false seronegativity, then your HLA determination would be beneficial. And then this has to do with the biopsy, basically. What's recommended is 4 biopsies from the distal duodenum and 1 from the bowel. If the histopathology results come back as a Marsh classification type 2 to 3, then your celiac disease diagnosis is confirmed. But if it's between a 0 and a 1, then they recommend to revise the quality and orientation of the biopsy, consult experienced pathologist, and revise histopathology so that basically the slides can be revised by a more senior, experienced histopathologist in celiac disease specific. And then the adult diagnostic criteria basically follows a very similar system as the pediatrics, but here the guidelines, which are very interesting and very important, I found most useful was the European Society for the Study of Celiac Disease. They had updated guidelines last year, and that document is really, really great. So it would be, if you would like, I can send it to everybody, but it's nice to go through it. And basically they say the confirmation of celiac disease diagnosis in adults. We need positive celiac disease specific serology in patients and your histopathological MASH2 or 3-stage from your biopsies. And you can also have a no biopsy approach in your adults if your initial tissue transglutaminase IgA is more than 10 times the upper limit of normal with a confirmatory sample. But here they mentioned a confirmatory sample of your tissue transglutaminase IgA, and that doesn't have to be more than 10 times upper limit of normal. That can just be any positive will be fine. So these are just some of the points that are brought up by the European Society. They address certain specific conditions or concerns. So what is the role of the HLA-DQ typing? So it's important to know that HLA testing has a poor positive predictive value, but a high negative predictive value. So it's very useful in ruling out celiac disease, basically. So it's indicated when there's uncertainty about diagnosis and in the screening of certain risk groups. So you'd rather not expose or make a patient go for a biopsy if there's a very, very, very low chance of them actually having celiac disease. There are a small subset of patients in which the HLA-DQ2 and 8 are not positive and the patient can have celiac disease, but it's very, very tiny. And research actually is ongoing in this section to find more HLA types which are associated with celiac disease. And how to diagnose celiac disease in adults who are already following a gluten-free diet without the diagnosis having been made. They recommend that a gluten challenge be done. So basically, the indication, test requirements, and implications of possible outcomes needs to be discussed with the patient at the onset because if a patient is on a gluten-free diet and the symptoms have subsided, if they really, really want the diagnosis, they need to understand that if they do a gluten challenge, they might experience the symptoms. And it's actually, if you look at point 3, it's a minimum of 6 weeks that the patient needs to be on a gluten diet. So if you explain the possible outcomes and implications of the patient at the onset, then that ensures that the patient is a bit more on board and they might be more adherent to the whole process. Also important, just confirm the HLA-DQ and 8 before starting the gluten challenge because a negative result likely rules out your celiac disease. Then a minimum, as I said, a minimum of 3 grams per day of gluten for 6 weeks has been shown to balance the diagnostic accuracy and the extent of discomfort for patients. So higher doses or longer durations improve precision, but that's only if it's tolerated by the patient. And adjustments based on patient preference and symptom tolerance can also enhance adherence. So if your patient is really not dealing well, coping well with the 3 grams per day for 6 weeks, you can tweak it a bit to have a bit less. Obviously, you can discuss with the dietitian for this, and hopefully, you can get some meaningful information when doing the serology. And then the duodenal histology is the preferred endpoint for the gluten challenge. Symptom monitoring and serology can provide additional diagnostic certainty. However, serology may be considered a substitute for histology when your your tissue transglutaminase IgA titer is more than 10 times the upper limit of normal. Then basically gluten sensitivity. When can that be considered and what are the requirements to make a diagnosis? So that can be considered in patients with reproducible gluten-related intestinal or extraintestinal complaints, normal celiac disease serology, normal wheat allergy tests in your patients on a gluten-containing diet, and after you've excluded major organic GI disorders. It is, however, important to acknowledge the potential role of the nocebo effect in symptom development, as the clinical manifestation of your gluten sensitivity may be influenced by expectancy and actual gluten intake. So your patient psychologically might think or have symptoms because they have previously experienced improvement with a gluten-free diet, but it might not be, the symptoms might not exactly be caused wholly because of gluten. Culture testing offered by Pathcare, we have tissue transglutaminase IgA, and your total IgA. So that's the first line screening. Then your tissue transglutaminase IgG, your deamylated gliadin IgG for your patients who have a deficiency of total IgA. And then your endomysium IgA for your confirmation in the kidneys. And then your HLA typing DQ2 and 8 is a referral test that we do. And then the wheat allergy testing, which is the wheat IG and skin prick test. So the treatment of celiac disease at the moment, only known treatment is the elimination diet. So just to exclude foods containing wheat, rye, and barley. And then as just touched on before, controversy about the use of oats. They can enrich the diet with whole grains and nutrients, but on the other hand, some studies show that they contain traces of gluten. However, mostly patients do tolerate it well, and technically, according to the amino acid sequences found in their protein components, it should not cause any pathological effects. However, there are cons to this elimination diet, and they are that they can be lower in proteins, fiber, folate, some of the vitamins. They are higher in saturated fats because oftentimes there's increased meat intake, and it is in general a more expensive diet. If your patients are forced to buy poor quality products, that can further enhance the risk of deficiencies, nutritional deficiencies. So the new potential treatment strategies that are being researched at the moment. So the only known one that is actually working is the elimination diet, and that's been researched, but these are the new ones that have trials ongoing. So the use of bacteria, naturally, endopeptidases are naturally produced by bacterial strains and fungi, and they are capable of digesting prolamin-rich protein fragments into fragments which are non-immunogenic for celiac patients. So there's a lot of research going on to this area. And then also the other section is modification of your immune responses, the role of probiotics, systemic steroid therapy, and anti-TNF alpha antibodies. There has been research which show that they do improve symptoms in your celiac disease patients, but yeah, as I said, it's in the research section. And then interesting as a vaccine. So NextVax2 was designed to introduce gluten tolerance by modifying the T cell response. So after vaccination, the immune response to gliadin was significantly lower than in unvaccinated patients. And then the studies going into this vaccine have confirmed lower concentrations of interleukin-2, INF gamma, as well as lower CD4 T cell proliferation. And then since the problem is tissue transglutaminase, why don't we just inhibit it? So studies in mice have shown that a complete congenital deficiency of tissue transglutaminase leads to numerous complications such as glomerulonephritis, splenomegaly, and impaired phagocytosis. So a complete deficiency might not work, but there are studies which are checking if there is a role for some sort of inhibitor for the tissue transglutaminase. And then from the pathophysiology side, zonulin inhibitors. So in celiac disease, according to the pathophysiology, the contact of gluten with the intestinal mucosa results in the increase in zonulin. So that leads to enterocyte tight junction dysfunction and increased mucosal permeability. So larazotide acetate was developed with properties to regulate the tight junctions between the enterocytes and to modulate intercellular tension. So that would inhibit the zonulin effects. And this leads to a reduction in the permeability of partially digested gliadin fragments, and thus the reduction in the immune response that follows. So larazotide has been shown to promote the repair of enterocyte structural defects. So in conclusion, celiac disease results from a complex immune reaction to gluten. There are many non-specific manifestations of the disease, so clinical suspicion should remain high to investigate patients. Laboratory diagnosis is advancing with the no biopsy approach being favored, especially for children. Testing of tissue transglutaminase IgA and total IgA is recommended as your first step screening. And currently, the only recognized treatment for celiac disease remains a gluten-free diet. Thank you for your time. These are some of the references.
Thank you so much. This really, I thought I knew and understood the celiac disease, but clearly I don't. So it's kind of, we always have tested for it, but I think probably our knowledge was limited. So thanks for highlighting it in more details. Just something which is probably, I think I'm going to the guide is infertility. Because we have a lot of infertility issues, obviously, in society. And I don't think many guys understood that actually celiac disease is one of the causes of infertility because we don't see those tests being done. Does celiac disease cause primary and secondary infertility? And what will be the mechanism? Because I don't know how to link between the two.
Well, what I've read is that it's linked mostly to the nutritional deficiencies, and then it causes the sperm. Okay, on that side, on the male side, the sperm.
Oh, it's on the male side.
Well, no, on the female side also, but just explaining. Starting off with the male side.
Because the gluten got in the sperm also, isn't it? It's not the same. Well.
So it's the combination of the nutritional deficiencies and your inflammation.
Or sorry, inflammatory. Yeah, DQ. You mean maybe the DQ, the HLA related with the cytokine inflammation.
Yeah. Which then causes the infertility on the male side, the sperm is affected, and then on the female side also just your ovulation is then affected by your deficiencies and.
So we think the guys should also test for that.
Well, I think you did mention something like that on one of your first slides about that whole metabolic syndrome, ovulation issues, and all of that.
Because giving everything actually, yeah. That's the reality. But also I think it's very good for weight loss. Am I wrong? If you get this
No. As you said, remember now, if you don't eat wheat, you eat other things. So now you eat more fats and saturated.
Then you must eat wheat and you lose weight.
And what he's saying is that if you're having like a diarrhea or something like that would help. That's what he's trying to say. But of course, nutritional deficiencies. Yeah, your gut and uncomfortable. Some absorption essentially.
So, two things. So why is it more common in females? Is there? I've never seen it in males.
Okay, I never thought of that way. Females.
It's mostly females associated.
Isn't there stress creatures?
I don't know. And then on the empath form of, I normally was to remember all those antibodies. No, I normally just write celiac antibodies. And then what do you give us? You give us an IgA and
transglutaminase IgA.
Yeah, and that's a screening one that we test for.
Yeah. And I'm not too sure on AMPAT side what they do. Like on our side, if you ask for celiac screening, it's a tissue transglutaminase IgA, and then it reflexes if the tissue transglutaminase IgA is negative, it reflexes the EMA. It reflexes the gliadin IgG.
Yeah. Just recently saw that. So they did that.
I'm not doing the three of them all at once. I don't. But now I understood better. But before I always do all three of them and then see what come out. Yeah.
But if you want to answer now, then doing all three of them would sort of help. But if you want to follow the algorithm, then it's best to just do it.
I think this is a very good disease for actually. I think for us, we see them in the context of asthma, obviously, when patients on asthma, then sometimes they have to do relations. But I tell you, no, my child is when he eat this and develop mucus or something, epigastric pain related to asthma. So we always don't get this really. Yeah, but I think because it's just an autoimmune disease with quite a lot of very interesting actually. Yeah, and then the issue, of course, the ecchymosis and particularly obviously, I think that obviously most people will consider thinking about obviously thrombocytopenia. But I saw that on your slides, it's actually giving more thrombocytosis. Because
It's more of an inflammation.
corrected, yeah. So it means somehow, yeah. How much would the platelets go? Do they need to go to over 1,000? Because I know when it happens, then they become dysfunctional. That's why you have those issues.
So if there's a iron deficiency worse, it will also come up.
Yeah,
The
with the
inflammatory,
thrombocytosis.
so it can go.
Yes.
That just tells you how much research has been put into place.
So it's rare that it should go above 1,000. It should not be that high. There must be something else because it stays within something.
And then the bacteria and ecchymosis, how do you explain that?
The technique ecchymosis is not from the thrombocytosis.
Okay, well, could be from any age
It
dysfunction.
can just be from the connective tissue component as well. It's an autoimmune condition. It's a systemic inflammatory disease. So maybe there's other associations. It's all from the thrombocytosis.
But when we always see that, it gives us a very nervous sign because we're worried about.
No, for sure. But I'm saying in this particular case, can be other things that's contributing to. And the itchiness, the IgE reaction, those kind of things.
IgA. And also the IgA deficiency means somehow your presentation is less.
No,
Or I mean IgA, we always got two type 1, type 2 deficiency. So does it have specific which one?
sorry.
IgA deficiencies, and you've got two. You've got A type A1 and A2. They're split into two. But then in South Africa, only do IgA total only. So does have to be particular one of them, or it doesn't matter, or total IgA. That's actually pretty nice. I love that. And okay, so I can still eat my oats. Well, Panel, do you got a case? Thank you so much. Any question online? Who is online? Dr. Kohli?
So one thing is I always remember from my
Online, who is online? There's quite a lot of people online.
these autoimmune conditions tend to stick together. So if you have one autoimmune condition, you have to go and look for all the other ones. So somebody with hypothyroidism can have another autoimmune condition with it. So, and this is a different autoimmune condition. So, I think we're probably missing more.
Yeah.
But the other thing is also a lot of patients come in and they will tell you, I've got celiac disease or gluten insensitivity because they already know through diets and they will avoid.
Results like on
So-
different diets,
Yeah. So, and I think Fritz probably sees a lot more because he does the biopsies and things like that. Gastroenterologist.
Yeah.
But yeah.
Yeah, I think it's just very important. I think because we just don't do a lot of it. But obviously, because in pulmonology, we don't get to, you can't, I think physicians will say a lot about the GPs. But of course, more especially that misdiagnosis. And some family, I just know that sometimes when you think of celiac, you have to think about the Irish, that particular. Am I wrong or is it a misconception?
It is a misconception. It's just because research had been done in that area before. But the research that's now happening, because epidemiology, it's everywhere. It's
Okay, so it's
just that we don't have statistics.
yeah, because
I always test my females, especially with iron deficiency anemia, where you can't find another cause. I always test for celiac disease. See if they have something. But doesn't happen very often.
yeah, because I think like for us, like in Central Africa, we tend to eat a lot of sugar. The sugar is gluten.
Sorry?
Sugar.
So
You know what sorghum, guys? No.
So
Sorghum, yeah.
make beer.
Yeah, but also you make a very good cup with it or something like that.
Yeah.
And then there's a break.
because I see it.
Okay, great. Because I don't like it. got too much fiber.
That's probably why we don't see a lot of males, because beer contains wheat or gluten. So even if you have pain, you'll just continue drinking. If
You're
you,
going to dump that
if, you have to
pain.
tell if you have to tell a male, sorry, you can't drink beer anymore, they might as well just start.
The worst is the beer drinkers are the Germans and Dutch, isn't it? Yeah, I think they drink, I mean, just like a
No,
normal.
the country in the world that drink the most beer per capita is the Czech people. Yeah.
But South Africa, isn't it also getting closer for that?
It's just